So the whole idea of this summit series is to help mainly the final year MDS students to crack the exam in a very nice manner. Everybody who has attended the previous courses conducted by iOS, I'm sure are all well geared up. But we thought we'll take up some topics which are a little offbeat. And in fact, the way we started was by reaching out to some of the final year postgraduate students whom I knew personally, and I must acknowledge their contribution in helping us with deciding some topics which they really would want to understand and be addressed by some of the faculty. Even the faculty members, most of them who are very well known to all of you, have joined in from different parts of India, and they have tried to give their level best to make you understand a little more of the nuances of the topics that they're going to cover. So the way the whole summit series would go, I'll be explaining in the last part of this session today. But let's get started on the Sunday evening with Sunday morning with some insightful discussions about three different aspects. And the first topic that we're going to cover is the common mistakes that most of the examinees would make. And again, here it is more of a discussion, I would say, and the inputs which have been provided by three senior heads of departments as well as examiners, MDS examiners, and those who have also finished the board exam, IBO, as well as the MORTH RCS. So I should acknowledge their contribution also to this. And following this talk will be just a half an hour talk. But following this, there will be a very insightful lecture by Dr. Jayesh Rahalkar on making treatment planning demystified. And this is something that is quite an enigma by itself for some of the postgraduate students when you attempt the exam. But he's going to make it very simple, and he's going to break it down into simpler pieces. And then we'll have a talk by Dr. Vinod Krishnan, and he's going to talk on the iatrogenic effects of orthodontics. So let's, without further ado, let's get started with the first talk, which is on common mistakes made by examinees. Now, before I go into the mistakes per se, let's see what is the main objective of MDS itself. The MDS in orthodontics or any other faculty, I'm sure, the main objective that is reflected upon in postgraduate studies is to understand and make the exam much more, and most of you are familiar with this movie, Three Idiots. So Amir Khan says, Kabil bano. That means you have to become proficient in what you're doing. That is most important. Don't keep running around trying to learn only big things or things that you think are going to help you in the future, but try to get proficiency in as many things as possible. And most of you are already well versed. Those of you who are exam going in the next couple of months, I'm sure have prepared very well. But what we are going to do today and in the next sessions that are going to follow on starting from 22nd, the 2 weekends on 22nd and 29th, is trying to help you understand what are the problems that the students face, the examinees face, and how to tackle them in a much more meaningful manner, and make the exam more of a smooth sailing rather than a roller coaster. So when I view at what are the common mistakes or the challenges that we commonly see, and when I say we, it's a collective input from different examiners, as I mentioned earlier. And what I felt was the most important hurdle that one has to overcome as a MDS student is to plan with the preparation itself, preparation for both the theory and the practicals. And this is, I think, one of the early mistakes that people tend to do. We feel that only when the exam is close by that you start reading a lot, but that shouldn't be the way. In fact, my understanding is read much more, let's say a couple of months or 3 months before the exam, and as the exam approaches, your reading of new material should start reducing, and looking at only what you've read earlier and making those notes and reading from them becomes more and more crucial. So in my opinion, these mistakes that are commonly made by the examinees are more like the unforced errors when we talk of, let's say, a tennis or a badminton match. There are errors that are forced on by the opponent, but there are many, in fact, which happen because of your own negligence or unpreparedness. And it is not difficult to reduce these, but you need a little bit of a special focus on how to reduce the mistakes. So part of this reducing the mistakes or the problems that usually occur will be covered in this presentation. But subsequently, Dr. Jayesh will take it up today, and then in these the following sessions, which will be held on 22nd and 29, we'll be highlighting aspects that especially are related to the Grand Viva and how to overcome those as well. So I'm going to break this up into the problems and the mistakes that happen during the for the theory exam, and what is a simple roadmap that you can follow, which is what I used to do. I'm going to share that with you. And also I'm going to talk about what are the problems in the practical exams that you can face and how to overcome them. Again, partially will be covered today. So what is it that is expected from you when we say that you need to prepare well for your theory exam? It is the appropriate amount of reading that you need to do from various sources, which I'm sure you've been doing. You've been presenting seminars, journal clubs, your library dissertations, etc., and also the standard books that you read. But one aspect that we find most of the examiners also felt that is lacking right now is a backing up of your answers, both in theory as well as in the practical, with recent evidence-based research. And we're going to have a talk by Dr. Umal, who is going to cover on the evidence-based aspects of what is known currently and what you should be knowing as students for not just the exam, but also in terms of clinical approach. And finally, the presentation method itself, the way that you present your answer in the theory exam, we find that there could be a simple improvement, and I'm going to talk to you how you can actually do that. So let's get started with the theory exam. So when you look at students tackling the theory exam, it's as if they are squeezing their whole brain out and trying to get things that they must have read in the last 3 years, but it need not be so. It can be made very, very simple. It can be planned just as a cricketer would plan for a match, depending on the pitch and the type of ball that he is going to face. You know that these days you have the white ball, the pink ball, and all sorts of changes that are happening in sports like cricket. So our examination is something similar. You need to go through, get a feel of what is required from you. And the best way I feel is to go through a simple thing is to go through the last 5 years of question papers, not just your university, wherever you are studying, but also the nearby universities with the online training being quite prevalent. You can ask some of the friends whom you meet, and you can ask from the other universities also. And that's the point to get started. Once you know what is the usual pattern of examination, be the first paper or the second paper, my suggestion is that identify 20 to 25 topics which are most frequently asked, and you'll find these happening repeatedly. There might be a little bit of a variation in the way the question is framed, but then definitely it would be there will be some specific topics that you need to look up for. And there will be about 15 additional topics which would be uncommon but very relevant for the paper that you are studying. So once you have these, let's say 35 to 40 topics at hand, then is the uh, main thing that you have to do, in which you will identify these topics. You will have, let's say for each topic, you can have important authors, and you can also quote important studies, because then it becomes very, very important. And all the examiners, I'm sure they would agree, those who are here, that when we are correcting the theory paper written by you, the time that we get to correct would be just around 6 to 7 minutes per answer sheet. And in that period itself, we have to scan through or skim through what is the relevant data that has been put forth by the candidate. And therefore, you need to highlight certain things, you need to make flowcharts, etc. I will talk about that. But the most important thing, as I mentioned earlier, identify these important topics and make uh, the highlighting of the authors as well as the important studies that you are going to quote for each of these topics per se. And it's not very difficult. You can refer to something called as the Bristol notes also, which has a lot of references. Or if you have started studying right from the beginning, then it would have been a good habit to make references or cross check with the references at the back of each chapter. So there is another simple thing that you can do in your theory paper itself. Always get into the habit of putting a basic flowchart as to what you are going to cover in the question that has been asked. And this would be easier for the examiner also to understand. And a simple way to get started with that, since most of you may not be doing it, would be to go through what are called as the mind maps. And I'm taking help from a simple mind map that was given, that is mentioned in Declan Millet's book. And there are several of those, but you can make your own. So for example, if there is a question on, let's say, reverse overjet, what is it that importantly has to be covered in the answer itself? So necessarily you have to cover the prevalence as well as the etiology, the investigations that you're going to do, and then the variations that can happen in the diagnostics itself, and then how you're going to manage depending on the age, depending on the severity, what kind of treatments you can look at, and all these things. So you can go through these. It's not very difficult, but importantly, try to make these for each of those topics that I mentioned earlier. And once you have these flowcharts, even the revision becomes very simple. Reproducing these in the exam also becomes a sort of a cakewalk. So this, if you start doing, would make life very simple for you, especially with respect to the theory exam. And of course, we'll be discussing some more things in.
Chetan, your voice is not heard.
Am I audible?
Yeah, now it's
Yes, better now.
Better? Okay. Yeah. Case it is not heard clearly. So should I go back to the previous slide, Vinod? Where did you lose
no,
my
just now only, just now only, just now only. You can
just now?
continue this.
Okay.
Yeah.
Okay.
Start from
Right, right,
beginning of
right.
this slide, Chetan.
Yeah, okay. Thank you, Jayesh. Vinod. So the examinee preparation, as I was mentioning, is according to a set format, and it's not difficult for you to look at the individual components and plan. And what is very important that the examiner would expect is the confidence that you display in individual components. Examinees who are very tensed up, who tend to falter, who tend to say yes to everything that the examiner says, the examiner obviously would understand that this is a little bit of a doubtful candidate, if I may say so. So what do you do? How do you plan for individual components? So I'm going to talk about the byte registration part itself. Dr. Jayesh is going to talk on the long case, so I won't go into that. And I'm also going to talk a little bit about how to assess your own cases that you're going to keep for the examination. So in terms of the functional appliance component, you know that there are these three individual subsections. That is the treatment planning per se, in which you would record the case history and plan for it. I do not know how it's going to happen this year, especially with COVID again being rampant, whether it would be like previous year. But let's consider that you get a patient and you have to do the byte registration as well as the appliance delivery. How are you going to proceed with that? So the most common problems that have been identified by the examiners and myself are very simple things. And if you keep a note of these, and I'm going to also tell you some viewpoints about byte registration, your first impression itself will be a good one. And once you make a good mark in front of the examiner, then he or she will always look forward to asking or getting more information from you, and you gain an upper hand in the exam as such. So the most common problems that one can see with the examinees is that the simplest thing, like for example, the midline assessment before and after the bite recording, that itself is not given enough importance. In the diagnostics part, implications of freeway space and the clinical measurement of this, how do you record it extraorally, these things are not understood or presented properly. And also the way in which the bite, construction bite itself is presented to the examiner when after the second part of the or the second component of this exam goes through. So in terms of the treatment planning, I'm not going to go into details because Dr. Jayesh will be covering it. I will stick to mainly the construction bite, which is the second component of this. So in the construction bite, if you actually look at, there are only four things that you need to understand and go ahead once you are focused on achieving or looking at these four things. It makes your life very, very simple. So first is obviously looking at the VTO based on both the overjet as well as the molar relationship consideration. Because what I often see is that whenever we are looking at class 2 Div 1 patients, everybody tries, or most of the students would look at only the overjet and try to get the maximum advancement possible. But no, that's not the right way. The important thing is to look at what or the existing molar relationship itself. What is your objective? How do you want to correct it? If it's a asymmetric class 2 molar, then how do you correct on either side, looking at the midline also, and give more importance to the soft tissues, which is reflected in the VTO, because most of the time you would see that the upper incisors are severely proclined, and therefore that adds up to the existing overjet or the overjet that you need to get corrected using the functional appliance. And the third important consideration is looking at the chin advancement as well as the molar relationship correction and not the overjet per se for the construction bite. The second thing is looking at the postural disposition and the overbite improvement that you wish. Because most of the class 2 Div 1 patients, class 2 Div 2s also would have a severe or increased overbite. And how do you correct it? How much of it can be improved upon just by opening in the posterior region is all dependent again on the soft tissues and what makes, how much is the patient short of in terms of the vertical third in the lower part of the face, and how do you improve that. The third important consideration is to look at the inclination of both the upper and lower incisors and then plan how much of advancement you actually need to do. And finally, as I mentioned earlier, the midline, and give importance to both the skeletal midline as well as the dental midline for addressing this aspect also. So there are various viewpoints of this. I won't go into the details right now, but make sure that you take the maximum forward posturing of the mandible in a patient and try to record it depending on whether it's a low angle case or a high angle case. And in a high angle case, the vertical opening will be changed or opening also. And as is mentioned here, sagittal repose. So let's see one simple case in which the mandibular advancement and the construction bite has to be recorded. Make sure your impressions are of good quality. The models that you have for demonstration are also made well and kept presented in a very nice manner. In the initial part itself, try to record the vertical third of the face, help the patient identify how to maneuver the mandible forward, make him or her do it 2 3 times before you actually put in the construction bite. All these would take just about 2 to 3 minutes extra. But the bite that you take, the construction bite that you record, should be done in one single go. And this is definitely possible if you train the patient very well. And this is a very, very common mistake that I see, that examinees tend to neglect, and they directly start, without making the patient very comfortable with you, start maneuvering the mandible using manual pressure. And that's not a good way to do it. So make the patient comfortable. And once the patient is comfortable, make sure that the mandible is fully engaged. the patient's mandible would be advanced. My only problem with this is most of the time the wax would overlay and cover the incisors, and then marking the midline becomes a little difficult. But you can definitely do it in a couple of times. Take the construction bite onto the cast, and again trim and polish the wax, and again put it in the patient's mouth and then mark the midline. That's one method. The other method that I typically follow in the practice is what was given in the second edition of Prophet, in which they have shown a little modification. The way the wax itself is placed over the model, the study model, is different. The anterior part is trimmed off, and the wax sheet is layered in such a way that it covers the posteriors only. And then the mandible is brought forward into the necessary advanced position. And the midline, the vertical opening, the amount of clearance that you're having becomes very easy to look at in this particular method. So I generally recommend using this. But for those who are right now exam going, it don't change whatever you have learned. Whatever method you have learned, stick to that. The important things are make sure that there is a bilateral advancement, equal and bilateral advancement. That is, if it is necessary to change, then only in a skeletal midline, if at all, you have to change. You have to record the vertical increase on the external part, not after the examiner asks you, but much before the examiner asks you. So you have to record the vertical increase and make sure that the bite is well polished, kept on the models with the marking advancement that one has achieved on the study model itself. So these things are very simple, but these have to be done necessarily. I'm sure the students have been doing construction bite registrations, but follow these steps and it becomes more easier for you. So this is one part of it. Now let's go to the next section, which is usually either the bonding or a wire bending exercise that would be given as part of the MDS exam. And the common problems that the examiners have pointed out is again, certain things are very simple. For example, you want to place the brackets in a particular manner following the MBT chart, but when the examiner comes and checks and asks you for which chart did you use in this patient, they wouldn't have it because it's probably taken from the case record that is already given to the patient. That's not a good thing to do. Make sure that you record it separately on either your own exam sheet if it is given, or you make sure that you have a plain sheet on which it is placed. Now, we are all human. We may err a little bit. So there might be an improper placement in one plane, and that's the maximum that would be allowed. You can't have the improper placement in all the three planes. But if it happens, you should be knowing the implications, and if it is a gross error, then you should be able to explain how you will rectify it, how you're going to change it. And that is the most common thing that would be asked again. You have to give a lot of importance to the material properties itself. So let's say the bonding material that is used, the various generations of these, the curing lights. What happens is we would have read a lot of other things, but the simplest things such as the curing light which you are using day in, day out, you wouldn't remember what is it. What are the properties of the curing light that you are using? What are the newer curing lights that are there? With some recent studies, if you can back it up. And the other typical question that the examiner may ask is, suppose this one of the brackets get debonded, how are you going to manage such a situation? So these are things that shouldn't come as a surprise to you. You should be in fact prepared. And my bet or my way of looking at an exam is actually you can guide the examiner into things that you know better, and that's a trick that you will happen only with practice. So this was the second exercise. Then the third exercise, or in the second one, either you will get bonding or you might get the wire bending. And most of the time, they would be asking you to do a frictionless mechanics, a wire bending with Kaiser loop or a T loop, and whichever loop that you have been taught about. You can say that I'm more comfortable with this, just as most of the examiners understand that the byte registrations could be made for, most commonly it would be the twin block or the bionator, but sometimes they may insist on other appliances also. So likewise, in the wire bending, they may ask you to do a different type of a loop mechanics. But what is important is you should understand the basics of frictionless mechanics. Go through the important sources, especially that of Burston. Then recently from Nanda's book, you can refer to our book on biomechanics as well. A lot of information, basic information is given. Remember one thing, that the examiners are not there to try and understand a lot that you know. They wish to make sure that you would be, if you're allowed to pass, then at least you are a competent orthodontist, and therefore you should know the basics of each of these aspects or the components of the exam. So for example, alpha beta bends, most of the time people are confused. So go through the necessary sources. We'll be providing this on the platform itself after the last session is over, and you can go through that. And you should know, though you may be practicing, let's say, sliding mechanics, or you may be doing frictionless mechanics using a particular loop, but you should know what are the other common loops and their clinical handling, because anything could be asked with the in the exam. And you should also know what are the problems associated as well as the management that you're going to do. So this is very, very important. So this is another part of the practical examination itself. Now, what about case presentation? You are asked to display your own cases. The most important thing that I feel that the examiner should be good at is trying to look at the different types of cases and how to present the case. In fact, Dr. Jayesh took a nice lecture in one of the earlier sessions that the Indian Orthodontic Society had organized. I had heard him. So most of you would have heard what are the important aspects of case selection that he had recommended. The other important thing is make sure that you have proper records of all these cases. A simple example, let's say it's a periodontally compromised patient or an adult patient for adult orthodontics. And often we find that the examiner would not have kept the pre-treatment, let's say the IOPAs of areas that are periodontally compromised. And how do you record it? It's not enough just with the OPG. You need to have additional records also. Most of the MDS examinees would go through a protocol in which the instructors would give them a line of treatment and would be supervising it. But it is your duty when you're facing the exam that you should understand the detailed rationale for treatment, because it is you who have taken forward the treatment as such. So if the examiner finds that you are not confident in the rationale of treatment provided itself, then they will have some issues or doubts about it. And again, as I mentioned earlier, it need not be, we cannot expect everything to be perfect in the exam cases that you are going to display. So you should be able to critically appraise for yourself and put it in the case sheet. And then it becomes impressive to the examiner that he or she, that you have already looked at what are the critical points, and they may identify some more and tell you, you should be able to answer to that. So this is in short. But then if you look at, yeah, and of course, proper superimpositions to document changes, this is something which is very important. And we see that the students tend to overlook this aspect also. You tend to do most of the other things well, but don't document in terms of the superimposition. Cephalometric changes are fine in terms of the numbers, but when you have a visual presentation by way of a superimposition, it catches the eye much better. So you can go through some of these sources that I'm referring to now. In fact, this is an interesting article in the AGODO 2017 regarding the ABO problems that have been noticed, and these are the common errors. And even there, they would talk about these things which are common across the globe. I would say these are the common things that even you need to record. For example, the detailing and the finishing that one has to look for, that is not adequate. Starts from the inappropriate treatment objectives itself in terms of understanding what you have done. Then the increase in the intercanine width and proclination of the lower incisors, and which is not necessary in certain cases, even intercanine width expansion. You need to record these things much before. Do not wait for the last day or just the last week, and especially after the theory exam, to record all these things. Try to have a note of this in your pre-finishing records itself, and the poor control of the vertical dimensions. And these are some of the common problems that even as Indian examiners, we have seen the same thing. So what you can do is, and this is something from a previous lecture that I've taken on finishing and detailing, for all the students who are doing your finishing right now, you can follow this A, B, C, D, E, F. So A is for alignment and looking at the arch form, pre-treatment versus the present. B is for bite considerations as well as the buccolingual inclination, as well as the Bolton discrepancy and whether you have addressed it properly. C stands for correcting the tip, torque, midline, marginal ridges, and the contact points. These are taken from the ABO guidelines itself. I'll show you the article in which this was given. D stands for delegation, especially if it's a interdisciplinary case, how you have interlaced your treatment with a periodontist or a prosthodontist, endodontist, etc. E stands for the aesthetics, pre and post, and whether you have addressed etiological factors if they were present. And F stands for the functional occlusal criteria. Now use this simple guide for all your cases, even before you present them in the exam. Take up the records that are available to you now presently and try to look at these important attributes. In fact, you can look at this particular article, which is recommended all across even India now, and this is from Pauling study, or the article that she had given in AGO 99, and she talks of how you can use the guidelines that one can use. And in fact, it's a simple chart that you can make for your own case and try to understand it. So likewise, you have an excellent article by Dr. Karad in our own journal, the JIOS, and you have some other studies from the AJODO. But I would recommend that you go through some of the finishing series from, especially from Dr. Ashok Karad and even Senior Professor Jaide. He has written an excellent article in the JIOS itself. So this is about one part of the practical exam. And what is very, very important is when it comes to the case defense that is given to you, the long case, we would urge you to follow certain things. So one is follow the systematic route to diagnosis, goal-oriented treatment plan, and most importantly, keep some alternate treatment plan at hand, and don't be surprised if the examiner asks you. And this is something that is very important. Dr. Jayesh will talk about it, so I'm not going to go into the details of this, but just remember that everything should be goal-oriented. And this is from Dr. David Sarwar's article. You can go through that part as well. What about the grand viva, which is usually the last part, which would be taken for you? I have seen that the examinees tend to, especially if they are not very sure about certain things, start talking a lot and go all around the bush. That's not important, not necessary at all. In fact, the examiner will not like it. So answer to the point, that's the most important thing. Try to use as many references as possible that you would have made notes about, and you can go through for especially what you have studied. And most of the time, the way it starts is you present your long case and the viva stems from there itself. So in the long case, try to understand the case, the nuances of the case, especially if it's a surgical case. Let's say you would be asked questions about surgery first, and what is the role of TADS in minimizing the extent of orthognathic surgery, and how you can camouflage certain skeletal malocclusions, etc. And you should be ready with that. And one typical thing that I've seen with many of the examiners is sometimes they just put it as an open question to the examinees, saying what is the topic that you are comfortable with or that you have studied well. Now, when that happens, suddenly you shouldn't be dumbfounded. It's better that you have 7 to 8 contemporary topics, could be your seminars or the LD that you have done, and some other topics which are very contemporary, especially, let's say, digital orthodontics, or looking at the things that I mentioned just and the TAD skeletal correction or camouflaging. And whenever this is asked, you should answer to your strength, and then you are leading the examiner into the correct territory. So this is how you should face your grand viva also. So these are in a nutshell how you can go through the various things. Now, I will end by giving you a very simple method that I used to follow, and I still encourage all the students to follow, is to make your own short forms or let's say a mnemonic if you can, but otherwise, most of orthodontics can be broken down into a simple A, B, C, D, E. For example, let's say objectives of leveling and aligning. What are the A, B, C, D, E's here? So there is a ready-made thing that you can come up with. For example, for leveling aligning, arch form anchorage, the bracket alteration when it is required, the correction of midline as well as cross bite, deep bite or open bite management, how you will do, and what is the mechanics that you are going to follow. You stick to this and you can answer very well for this particular topic. Likewise, if there's a question on functional appliances, or even when you're planning for functional appliances, if you look at again the A to F or A, B, C, D, E, F here, it makes it easy. I'm not going to go into the details of these, but you can take screenshots of this and then try to understand if there are any difficulties. We can definitely answer at the end of this session or in the subsequent sessions itself. Likewise, for pre-surgical orthodontics, again, you can create your own ABCDE, how you need to manage each part of the pre-surgical orthodontics you can look at, or finishing and detailing that I mentioned just now, the ABCDEF. So this is a simple way by which for even very complicated or long topics, you can make your own nutshell answer, keep it ready in your mind, and whenever required, you can address it in a simple way. And this is something that has helped me all across. I'm sure it may help most of you if you follow this particular trend. And I would like to end by saying that it's also that the ABC that the examiner also notices or tries to understand in you. Do you know what that is? A stands for the appearance of the candidate, especially in the practical examination. I've often seen some people who come as if they've just woken up and not dressed well, not ready for the exam. You know, the shabby examinee is the first thing that becomes a sort of a let's say I would say just a sort of a repercussive mentality from the examiner's point of view. He wouldn't like it. So make sure that your appearance is more clear, dignified. Second, the B is the basic knowledge that you have or you have accumulated in the 3 years, how you're able to present it in front of the examiner. And the most important is the C, which is the confidence as well as the clarity with which you present. It's not just that you are confident about something. Sometimes you go overboard and become overconfident, but it's the clarity with which you can actually present what you know, which makes a big difference to the whole system of the examination. So with that note, let me end this particular presentation. And since everything is happening online, you never know. I mean, this time the examiners may decide to give, or rather your university to give you the degree. Click here to toss the cap into the air and you are online. And on the webcam itself, in an online way, have your graduation ceremony. Let's hope that doesn't happen, and hoping that all of you are doing well, your families are keeping safe. I would like to end this presentation. Thank you very much.